This is Thrivenomics, presented by Thrive Mortgage. Hey there, welcome back to another episode of Thrivenomics. Very excited to have you with us. Joining me today in studio, Michael Jones, no stranger to Thrivenomics.
That's right. Hello.
How are you doing, Michael?
I'm good.
This will be the fourth time that you've joined us for an episode. Two of them were just interviews with you, and then also a third interview with our special guest today. And so now makes time number 4. You might as well get comfy.
I will.
All right.
I know.
Change your title to CFO / co-host.
That's right.
Awesome.
Yeah.
Also joining us is the disembodied voice of Raul Espinoza, up there running the board and all things podcast related up in our Dallas office. So hello, Raul. How are you doing today?
Yes. Hello. I'm excited, actually. I'm real excited about today's show.
I am too. And let's get into exactly why we are excited. We back in April, when all of the COVID-19 craziness kind of made it to the U.S. shores, we invited a special guest on named Dr. Marty Makary. And Dr. Marty is an expert. We'll get into his full title and everything that he does, but we had him back. It was episode. If you want to go back first and listen to the first episode, it was April. It was episode 6 back in April, and we had a really involved and very interesting conversation with Dr. Marty about COVID-19, what we knew at the time, what were certain things that we could plan for and expect. We wanted to have him back on again, so now it's been about 5 months or so since that initial interview, and obviously it's pretty. It's top news just about every single day. So we wanted to have Dr. Marty back on, talk about what the medical community has learned about COVID-19, what are some of the important lessons that we learned during that time, and talk about kind of next steps forward and what to expect from there. So, Dr. Marty, welcome back to Thrivenomics. We're thrilled to have you on today. Thank you for taking time out of your busy schedule to be with us.
Jim, Michael, Raul, good to be with you.
Absolutely. Well, Dr. Marty, what would you say are kind of the first things? Where should we start this conversation? Do we start with lessons that we've learned, or things that are kind of most impactful about what we've learned since the spring of this year?
Well, it is interesting thinking back on our conversation. By the way, I had a great time with you guys last time. So thank you. Us as well.
Every now and then, the only reason why we had you back on, just because you're fun to interview.
Well, every now and then when I get down in the dumpster, I go back and watch that, and nice. I get a nice boost.
Excellent.
Awesome.
So, well, I think all of us have been through something we've never expected here, right? And we think, how could this possibly happen? But if you look at the history of mankind, okay, we have had a relatively good, peaceful life, right? We think, oh my gosh, there was the financial collapse, right? There was 9/11, which was tragic, and now we're dealing with this. Back in the day, in a single lifetime, a people group would go to war and maybe lose a quarter of their population every 10 or 20 years. I mean, look at the history of Europe, look at the history of the world. We're living in a time of relative peace. So as crazy as it is, I am thankful that we have each other. Now, if there's anything I think we've learned, it's been that we should have an attitude of humility around something that we don't fully understand. You had everybody and their mom had a strong opinion about the coronavirus with little or no information about it. Right?
Yeah.
Right.
I mean, is that today's world or what? People have very entrenched positions around things they know nothing about.
Right.
And so, we're learning a lot about this virus every day.
Yeah. Yeah, that's true. I think there's a lot of people online too that's kind of where we go to, and we see a lot of quote unquote experts, and so you not really sure what is real and what's not. Right. And I think that's kind of like what a lot of us are dealing with. I talk about with my wife all the time, I don't know if mask or no mask, I don't know. I mean, I'm not a professional. I don't know. And when I look online, the only place I can go, there's it's a mixed bag.
Right.
This has been an information battle. The scientific battle has been one front, that is developing therapeutics and a vaccine. The other front has been an information campaign, because as we've learned, and it's required an attitude of humility. Look, when the Chinese doctors told me back early on that universal masking was an effective strategy, I got to be honest with you, I was skeptical. We don't do that here, right? It's just not something we do. That was a cultural sin, if you will. It was a blind spot. People would ask, why don't we normally do masking during seasonal flu? Mm-hmm. Our country has been oddly complacent about seasonal flu deaths year to year. 4 years ago, it was 81,000. It can be 30 to 60,000 a year. Probably one thing we've learned is it's never going to be acceptable from this point forward to be showing up to work, hacking and coughing and slobbering on people, consistently. Yeah. Right? One would think. One would think. But it is kind of crazy, to your point, Roel, looking back on a social media post that I put on LinkedIn. And I did the same for friends on Facebook, but of course on Facebook you select who you accept. But on LinkedIn, I accept pretty much everybody. So I've got thousands and thousands of folks on LinkedIn. I posted basically an early warning back in early March about, hey, take this seriously, get ready, start developing contingency plans. Businesses should start thinking about non-essential travel being curtailed. Schools should think about contingency plans. Restaurants should start thinking about the delivery business. Way back in early March, and I was looking back over the comments. I don't know why. I think somebody added a comment recently, and it sort of pops up in your inbox. But the amount of hatred, right? The amount of denial. I mean, the CEOs, fellow doctors, saying this was crazy. What do you know about the virus? I mean, I think if anything, we've all learned a bit about humility here from this virus. Right. But things are looking good now. Things are on the up. Things are looking good right now.
Well, good. Okay, so explain that real quick. What do you mean by they're looking up?
So we've been told that we need to wait for a vaccine, and you hear this cliche phrase on the media. I mean, I think I heard on CNBC, they actually have a commercial. We're going to provide minute-by-minute coverage on the pandemic until there's a vaccine. Well, guess what? Therapeutics are looking like they're going to beat vaccines to market. There are 15 therapeutics in phase 3 trials right now. There's only 3 vaccines in phase 3 trials. Now, therapeutics may be a bridge to a vaccine, but it may be that therapeutics knock the mortality down another big notch. Because when we didn't know what we were dealing with in early March and in the early days of New York, the mortality was very high. Since then, we've gotten a lot better as doctors. We got learning about less aggressive ventilator management. That knocked the mortality down. We learned about dexamethasone in June. That knocked the mortality down by maybe a third. We learned about remdesivir. That knocked the mortality down. We learned about anticoagulation. That knocked the mortality down big time, preventing clots in the lungs and other places. So we've gotten the mortality down very low, okay? Another big therapeutic, like one of the monoclonal antibodies, could knock it down below levels of seasonal flu. We could actually have a coronavirus, COVID-19, with a case fatality rate below seasonal flu with one of these monoclonal antibodies. And it's pretty exciting because unlike vaccines where you have to give it to people to test it and then wait around until they get exposed to see if they get the infection, therapeutics, you just give it to somebody sick and you can immediately observe if there's a benefit. So those studies are conducted much faster, and it could be by late September, early October, we could be seeing FDA approval for a monoclonal antibody. That's an injection that not only treats but may prevent the virus.
That's awesome. That's excellent news. And I want to just take a moment to pause because, I mean, that's fantastic information to hear, especially with the reduction in mortality rates. But thinking back to what the health response has been, both from a federal and even from state level, because I know the states have jumped right into the mix to try to offer their own guidance. In hindsight, and preparing for what inevitably will be another pandemic that we experience probably in 10, 20, 30 years, what would you recommend that the federal and state bodies do to really assert themselves as the trusted authority so that individuals can trust the institutions that are in place versus their next door neighbor or what their personal bias may be?
Well, I think it's good for us to listen to medical experts. I think one thing that we saw here was everybody's opinion was flying around. Medicine had not yet had the data to learn. And I think we need faster systems to be able to learn quicker in the future. You actually had situations in Texas and around the country where a political leader would say on a local level, we're not doing this or we are doing this, but the hospitals and the doctors would say something else. They would say, no, take this seriously. And so there was a bit of a mismatch. Now, eventually everybody got on the same page, but it took a tragically long period of time. Look at the way that Europe suppressed the infection after out of control outbreaks throughout Europe. Wide acceptance of the medical community and the science, non-politicalization of the issue, universal masking, people distancing early, and decisions made on a big scale, not left to every mayor in the country to decide. So I think we've learned a lot, but I think number one, to answer your question, we got to get better data. It was really pathetic, and it still is, to be honest with you, how slow the data is to come around. Why are we learning about pediatric post-inflammatory condition in June, right? We could have seen this in the data early.
Right.
I've been fighting with Medicare to get data, and the data could be a lot faster. And I know Health and Human Services has done a lot to streamline that process.
Great.
Any follow-up?
No, that's great. I appreciate it.
Okay. Well, speaking of data, I know that there were a lot of, for lack of a better word, quote, villains being touted in the media, or whether that media is the actual media or social media. A lot of things being said about the World Health Organization, and that don't listen to WHO, listen to the CDC, and then others were saying no, don't listen to CDC. There's these doctors that went and had a presentation on the steps of Capitol Hill in a viral video. So, what when you say when you're talking about data and when you're talking about the sources of those data, who is it that you're listening to?
So I think we can learn from two things. Number one is the published scientific literature, that is studies conducted with good methodology that get out in the public domain. The other is clinical wisdom. And there is broad consensus among physicians on a lot of the big subjects, but we did not really see that consensus. There was an information problem, right? A transmission problem with the information. We physicians are not really great at communicating public health messages broadly. And that's why I've taken, the liberty of saying yes to going on Fox News and saying yes to writing about this and putting op-eds in places like the New York Times. Is we've got to do a better job messaging, right? We can't be talking about spike proteins in our little world and going to our own medical conferences and just talking to ourselves. We've got to communicate to the public, right? The battle is a messaging battle in part. And I think what we saw with the WHO is that they're all over the place, right? And some of it is an exaggeration of what they're saying. Some of it is they don't know what they're talking about. It's just an insufficient amount of data. I was at the WHO, as you may know, working on the surgery checklist years ago. And in my 2 years where I spent a lot of time there in Geneva, I saw a massive bureaucracy, and I also saw some great people doing incredible work. So it's mixed, right? Most things are mixed. The federal government is mixed, right? There's some great work and there's some work that's wasteful. And so you have that at the WHO. I think that for a lot of countries that don't have a CDC, the WHO becomes their de facto CDC.
Gotcha. Okay. So in relation to news sources, is there any particular, and not looking for you to name like a particular network or anything, but are there any resources out there or any media sources that are really getting it right, that maybe don't have the full attention of the U.S. population?
I think there's a couple really good ones. First of all, I would say follow Scott Gottlieb, Dr. Scott Gottlieb on Twitter.
Right.
I am also connected to him, so I retweet a lot of his stuff. I try to post things as well. I'm the editor-in-chief of MedPage Today, which goes to about 700,000, or about 3/4 of the U.S. physicians in this country. So we try to put out reliable articles. You can see MedPage Today. I think we're doing a good job putting out good information. And then I would say finally, that's probably good. I would say that's
Start there.
Yeah, I would say, you can read the medical journals yourself. You can look at the summaries. MedPage Today tries to summarize them for you. Kaiser Health News is pretty good. ProPublica is pretty good. There's some other good ones, but if you just follow, in the spirit of giving something that's simple to understand, the Twitter feed of Dr. Scott Gottlieb, and the posts that we do on MedPage Today. You can even get a daily COVID update. It's all free. You can get a daily COVID update email. I think that's a pretty reliable set of what we call kind of clipping services, where we kind of aggregate the COVID news for you.
Well, and I'll make a plug for following you. I do follow you on
Absolutely.
Twitter, and you comment, you retweet a number of excellent doctors and other sources. And so I would advocate that people even follow you, because you're following the people that you trust, and you know that their work is good, and you're sharing that information. So I've learned a lot. I've followed several of the doctors that you follow after you have commented and retweeted, and it's great because it gives me another perspective that I'm not getting anywhere else. So that's been a great resource for me.
Yeah, after we had you on back in April, we made plug for MedPage Today, the newsletter service, or the repository that you run, and we had that in the show notes, and I've been following it ever since. And there have been a number of things that were considerably over my head, but I show them to my wife, who's an RN, and she translates it for me a little bit. Yeah. But yeah, it's absolutely a great repository for good data, good information. So can definitely vouch for that.
It's amazing. Gottlieb nailed this thing in December. He was basically
2019.
Yeah, last year. It's amazing. That guy is amazing. I'm a huge fan of him, and so that he's really what cued me in to say, hey, I'm going to go down the hall and talk to the infectious diseases doctors at my hospital and see what they're saying. And sure enough, there was a massive disconnect between what the experts were saying and what we were hearing from people like Tony Fauci.
Yeah. I was actually on the way in. I was re-listening to. It was like my fourth download of our previous interview with you, and I was re-listening to it, and it happened to pull up right in the segment where we were discussing Dr. Fauci and how he and some of the other physicians who were the most vocal mouthpieces, more or less, were either not armed with the right data or were drawing the wrong conclusions. And I mean, not speaking ill of their past experience and their past contributions, of course, but yeah, it's just something where it seems like you were one of the first ones that was saying that, and it was over the course of a few months where that started to kind of become the narrative, is that, well, we got it wrong initially. So is there any follow-up to that that you would add from your perspective?
Well, first of all, I agree with you, Jim. Dr. Fauci is a great doctor, and he's served this country very well in many pandemics: Ebola, SARS, MERS, HIV. He's an incredible physician. He's got an incredible track record. I'm a big fan of Dr. Fauci, but he got this wrong. He missed it. And I think when the entire country puts their faith and stock in one human, and he is a human, he's like the rest of us, it's okay to get things wrong. We all get things wrong. But when the entire country puts their faith and stock in one person, and we just saw one person go on all the airwaves from January 1st to March 13th, and never once did we hear anything along the lines of, this is going to be bad, get ready, contingency plans, sort of like the things I was describing I posted on social and LinkedIn back in March. So again, a lesson in humility. I think there's no reason to demonize anybody. I think we can just learn here, and it is important we learn, because this thing is not over, right? We're going to be wrestling with coronavirus into this late spring.
Right.
Is that maybe a lesson for future leadership, both at the state and federal level, that they should not just have a single individual, but really a panel of, say, three from a couple of different areas conferring and sharing that spotlight moving forward? Because again, this isn't going to be the last time we have this rodeo.
Yeah, I agree. Look, we like to, celebrate individuals, worship individuals, and demonize individuals. And it's really not the way communities were designed, right? God did not design us to have one ruler of the earth where we just put all our faith and stock in that. And yet the media does that, right? That drives ratings. It drives hits and views on social media. It drives what Facebook and YouTube suggest to people to watch. And so I think we can, we should probably walk away from this saying we can learn from consensus and from community thinking, not just from an individual. I think it is a good principle of leadership.
Yeah, no, that's a very, very good point, and something I think our leadership should definitely take into consideration. Speaking of states and leadership and decisions, do you feel like there was any direct correlation between the phased reopening that took place in many states and communities, namely Texas? Texas seems to get Texas, Florida, and maybe one or two other states seem to be getting a lot of press right now as having the highest rates of infection per capita. Do you see any correlation? Is there data to support any correlation between the phased reopening and the spikes in reported infections, or was that something that was just simply bound to happen?
So I think the recipe is pretty simple. When people are more active, we see increases in cases. When those increases are resulting in some community spread, those increases can be manageable. What we're concerned about is not just spread, it's exponential spread. That's when things get scary. When 500 people test positive at UNC and Notre Dame and these other institutions within 1 week. College has been open for 1 week and we're not doing too well, right? We're having these massive outbreaks. And most college students, some say kids are kids. I don't believe that. I think most kids have been very conscientious and have been taking a lot of precautions. And they've been taking it seriously. And they've been doing exactly what we've been asking them to do. But for some kids, risk doesn't scare them, it appeals to them. And we've seen colleges take tremendous precautions around COVID, but then it all falls apart with an off-campus party. And that's where you can have this super spreading. So, we do have, our battle right now is, I don't think it is the person-to-person transmission in the community that we have been observing. I think we've got most people informed. I think most people are taking precautions. We finally all got on the same page. Our concern is exponential spread. And that's when you have a major setback. And, as we discussed and as I predicted, we're going to see rolling increases up until the fall when we collide with influenza. And let's pray for a mild influenza season. We'll probably know in a couple weeks. They do early predictive analyses on how bad flu is going to be. And let's hope it's going to be a mild flu season. We are going to see flu deaths go down this year because of precautions, and other flu years we're going to see deaths go down because people are now doing good behaviors. But the formula is pretty simple. If we take these basic steps, masking and distancing, we're able to manage it. And so we're seeing rolling increases really prove the hypothesis that the virus will infect 20, 30, or 60% of every community in the world. We don't know what the ceiling is, but it will get there eventually. So the countries that initially celebrated how well they're doing, guess what? Now they're starting to see outbreaks. States in the United States, if you remember, Florida, a state that I love, they were doing victory dances about how they did not get hit like New York. Well, again, it's good to show some degree of humility around a virus we have not fully understood. And one of those characteristics is a staggered and lagging penetration rate. And so we saw eventually those rolling increases hit hard in the Sun Belt. Well, now we're seeing some nice declines in Texas and the rest of the Sun Belt, Arizona in particular. But look what's happening right now. As we speak, we're seeing increases in the Midwest. So let's hope that this theory that herd immunity can be achieved at much lower levels than previously thought. Let's hope that's true. I really hope it's true. If you look at the theory that maybe we can get some herd immunity, maybe herd is not the right word, but we can get some community immunity, some real resistance to the virus at levels of 20 to 30% of the population having been exposed or infected. That is with antibodies, even if they didn't have symptoms. That would be good. Hong Kong flu, 1968, 150,000 Americans died. That's about where we are now. As a matter of fact, back then, 1968, 150,000 Americans dying is the equivalent of about 210,000 Americans dying today, adjusted for our population.
Sure.
And then it went away. It went away. And there was no masking. There was no, shutdown. There was no vaccine. There was no therapeutic. It went away. And now that virus is probably more fragile and coronavirus is more stable. So I wouldn't put a lot of stake in that. But let's hope that we might achieve community immunity levels at 20 to 30% infection, and then it goes away.
Oh, that'd be awesome.
Yeah.
Yeah, I'm ready.
I
think all of us are, right?
Exactly right. So you mentioned that. How many did you say that treatments? You said there was 15 that are currently in phase 3 trials. So what are are any of those different than the treatment methodologies that we talked about back in the spring? Because I know back in the spring there was this mad scramble for we need more respirators. Well, you don't hear that as much anymore, I don't think. At least I haven't heard. I could be wrong. But what are some treatments that you see are proving most effective?
Well, you're absolutely right. And the reason we don't need the number of ventilators we thought we did is because we've learned you don't need to intubate patients as early as we thought. We don't need to use the standard intubation criteria that we've been using for other lung diseases with COVID-19. That is, their oxygen levels can be very low, and yet they can still have decent cardiac and pulmonary function. So it may be that simple supplemental oxygen with, say, a nasal cannula or a face mask can increase that oxygen level without intubating patients. That was a big kind of breakthrough. Again, tragic it took us as long as it did to figure it out. There's YouTube videos of critical care doctors in an ICU in Italy begging on YouTube for doctors to understand that this is different. COVID needs to be intubated differently. We saw a protocol at Mount Sinai Hospital in New York get posted, and overnight hospitals started using it. That's what we're trying to do with some of this information dissemination challenge that I told you about. Right. But by and large, we're seeing exciting things happen, not just with those monoclonal antibodies, antivirals, and also we're seeing some traditional medications being used, things that block what we call the cytokine storm on the lungs. That is the body's response that damages the lungs that actually results in demise. So if you can block that storm or partially block it, it could help. That's how dexamethasone works. It's a steroid that's been on the shelf in the ICU for decades, and we've been using it for other seriously ill conditions, but it works in sort of slowing down the cytokine storm.
Yeah.
Good.
Yeah.
By the way,
sorry.
HIV. Remember when HIV happened, everybody was saying, a vaccine, we need a vaccine. Dr. Fauci spent, again, not to knock him, right? I like the man.
Right.
By the way, he's a very kind human being. He basically was talking about a vaccine incessantly and spent $5 million in taxpayer money on a HIV vaccine awareness campaign in anticipation of the vaccine. Guess what? We never got a vaccine. Antivirals are what allowed us to dig out of the HIV crisis. And that may be a predictor of what we might see with COVID-19. I don't know, but it may be that antivirals and the monoclonal antibodies, along with all the other things we're doing better now as doctors, that allows us to dig out of COVID-19, or at least temporize us until there is a vaccine.
Gotcha. All right. Raul, what were you going to say?
Oh, I was just going to mention that, you mentioned that you were hearing a lot of this on YouTube, some of the doctors talking, and I've heard a lot of what you're talking about on YouTube. And that was just one of the things I was going to mention is I feel like a lot of the videos that a lot of doctors that are talking on YouTube is actually very, you can get a lot of really good information opposed to like Facebook, because the algorithms on YouTube work a little different. Like it's not really about like shocking headlines or things like that to get people to click. It's more like related videos. So if you have a video that does really good, that's long format, that's how YouTube kind of recommends things. And so I found that I get a lot of my information, a lot of like what Dr. Marty's talking about on YouTube. And I think there's a lot of doctors can speak pretty freely on there. And that's how I've kind of managed to get a lot of what I know from the coronavirus. So it wasn't really a question. It was more just a comment.
Just a plug for social media.
Well, yeah, I mean, because I think it's so important. I mean, like right now, having Dr. Marty on, it's more of a long format, and I think this is going to go a lot further than a lot of stuff that you see on social media.
Yeah, agreed.
So Marty, I have a couple of questions I'd just be curious to pass along. So recently I saw a headline that somebody was attempting to compare COVID-19 to the 1918 flu. And I read, I think it was John Barry's pretty exhaustive book on that. And in reading that book and certainly comparing it to our experience now, COVID is nowhere near as bad as the 1918 flu was from my understanding of it. Would you agree that a headline like that is ridiculous?
Yes, the 1918 flu. Gosh, people say, this is a crazy time to be alive. Try any other time in our history. Try being at a time when, we're tragically sending, 18 and 19-year-old boys off to war. Try living at a time when 50 million people in the world died from influenza, as described in that book, The Great Influenza you mentioned. I mean, we didn't have good records. They weren't collecting death certificates in a central, repository back then. But gosh, the most tragic thing is that it selectively focused on infecting and killing people who were under 45 or 50 years of age. The theory is that people over 45 at that time in 1918 were already exposed to another virus, maybe another influenza in their lifetime, and that had created cross immunity. So people over 45 already had some immunity to the great influenza of 1918. And it's interesting because I don't know if that's true, but that theory has been circulated right now with why people under age 50 may not be getting hit as hard with the current coronavirus. Maybe they were exposed to other viruses, other coronaviruses, for example, that have given some cross immunity to people, albeit mild, to people under age 50.
Yeah, no, it's an interesting observation, and I asked this next question in light of how bad the 1918 flu was, because it was horrific. I mean, people were dying within hours of feeling symptoms in some cases, and just truly terrible. So, in hindsight, for any future pandemics and possibly even COVID, with 6 months under our belt, had we been able to have some sort of a massive trauma response, meaning we either had hospitals or we converted gymnasiums and schools and other things, would there have been some wisdom to attempting to get some of that herd or community immunity faster, or do we feel like that would have been incredibly irresponsible because we really didn't know how to treat the virus at the time?
Good question. I think when you have tragedies as horrific as being sick in the morning and being dead by the evening time for a 6-year-old or a 19-year-old, which is exactly what happened in the 1918 pandemic. I think the idea of, okay, we're going to go ahead and get the virus to create some herd immunity, it's very difficult to swallow. But if you remember, President John Adams, when smallpox was kind of going around, he had Dr. Benjamin Rush come up and give the virus to all of his kids. And, they got smallpox. The idea was if you give it to them, they might get immunity, but, that's what you get if you catch it in the wild anyway. So, look, we didn't really know what we were doing back then. I don't know if you remember, but chicken pox parties, there was this idea that, hey, get chicken pox as a kid, and it'd be better than if you get it as an adult. What we're basically doing is immunizing people by giving them the infection.
Mm-hmm.
Yeah. Well, my final question, I think James may have had one or two as well, is I have labored under the assumption for the last 2-3 months that I'm just going to get COVID at some point. I try to be smart. I wear a mask. I wash my hands. I use hand sanitizer. But I've also, I go to work. I go to the grocery store. We take our son to the local water park here. We try to go about our life as reasonably as we can. Is that a somewhat safe assumption that the average American is very likely to get COVID at some point over the next 6 to 12 to 18 months until this thing either runs its course or we get a meaningful vaccine? Or do you feel like there probably is a fair amount of resistance that the average American who's otherwise healthy and somewhat young can avoid this virus entirely? Because I know that's a huge issue for some people who feel like they can hole up and be safe, but I feel like at some point, it's going to visit you. So what are your thoughts on that?
The Reaper is coming.
Hopefully not, but yeah.
Well, look, we'd like to see you around. We don't want to see you have COVID or have a bad outcome. And I would say there's broad consensus in the medical community that taking mitigation steps can markedly reduce your chances of getting it.
Excuse me.
And it buys time. So I think the scariness and the sort of broad scale attack rate of the virus is not a fate that we have to accept. And we are seeing communities now almost able to reopen regular life, not just masking life, but almost outdoor activities with less stringent criteria, because they've done such a good job in taking mitigation steps. And I'm hoping that Texas becomes one of those areas where COVID becomes so rare and the treatments become so good that we can get back to a semblance of normal life. And it may be that we're going to do an inventory of everybody that has antibodies from either a previous illness or being exposed and asymptomatic without even knowing they had the virus, and figure out who's the 20% of Texans who may have the antibodies now, and let's go immunize the other, the rest of folks as best we can, right? Mm-hmm. And if we can do that, we might actually be able to, almost extinguish the virus. So I do think that we're winning, and I would challenge people to recognize that this is not a fate that we have to accept, that it will infect everybody.
Yeah, no, that's great.
Well, yeah, that's actually a really good segue into kind of how I was going to direct this to wrap up the conversation, was just talking about what you see as the best ways forward. So you mentioned Texas as an example. Obviously, we have a definite vested interest in how things proceed in the state of Texas over the next coming months and years. But what do you believe the next 6 to 12 months will look like in any community across the U.S. or even if you can extend it across the world?
So I think over the next couple months, we're going to see continued mitigation. That is, most of the country now with religion, understanding, what we have been preaching from a medical establishment, far less politicalization. Most people now are on board. They're seeing the effectiveness of regions of the United States that have done these simple measures and have been able to manage or control the infection. It's not a fun life. It's boring. It's lonely sometimes. Yeah. Kids start driving you crazy. But we could be looking at a therapeutic by the end of September. That's 6 weeks away or 8 weeks away. And that therapeutic could allow us to be a little more bold. And then assuming we get a vaccine that works in one of these phase 3 trials, that vaccine alone could increase our community immunity levels. Mm-hmm. And if, let's say, we only get 10% of the country vaccinated in the early batch that gets released, and you add that to the background, what we call seroprevalence rates of the antibody, that is, people that are already immune, let's say that's 20%. 20% plus 10% plus the mitigation, that may be enough, right? And that may be enough to allow us to resume normal life. So I think probably, if we're going to pick horses here, I'm going to say April will be the month of mass vaccination and the resumption of normal life.
Okay.
And if that ends up being the case, guys, have me back and I'll give you some lottery numbers.
Yes.
Absolutely.
Well, hopefully you would be back and we could all have a celebratory dinner.
Exactly.
Yeah.
Exactly right. I mean, one thing that's very clear is that our organization here at Thrive and you and your excellent research team are pretty well joined at the hip at this point, especially after Michael and Roy, our CEO, having read your book, which we'll definitely promote that and maybe pop up an image of it on the video recap. But your book, The Price We Pay, is a fantastic read for anyone. Michael, do you want to talk about how Thrive has basically contributed to the research efforts of Dr. Makary's group?
Yeah, absolutely, and I'll make it brief. But truly, Marty, that book, The Price We Pay, was really life-changing for us. As an organization, it drastically changed how we viewed healthcare spending and how we are trying to make an impact for our employees moving forward. It has spun up a number of opportunities, and I know Allison Kessler from our in-house team has really enjoyed working with you and your team on the efforts to reduce and battle balance billing, which is just so damaging to the American citizen, and just a major step forward in reducing overall healthcare cost and then insurance premiums. So any updates you would want to share that you guys have made in terms of advancing the cause there?
Well, first of all, thank you, Michael. I think Thrive is an incredible company, and the fact that Thrive heard about these disparities and these injustices against everyday Americans that go to the hospital and then just get destroyed with predatory billing and outrageous pricing that ruins their life financially. And I'm not just talking about their credit history, but also the amount of lost productive time that people spend sifting, filing, calling, getting transferred, getting the runaround and the finger pointing with medical billing. It's a disgrace. It's a disgrace to my profession of medicine. It's a disgrace to our system. It's a disgrace to our country. So thank you for your support. And I know, you mentioned Allison's been involved. She's been terrific. I know that all of you at Thrive have been with us in spirit, and we're winning. We're out there getting hospitals to behave, to use civility, and to give honest prices that are real, not inflated, and to treat people with respect. Look, if you bought a car for $15,000 from a car dealership, and you drive it off the lot and it falls apart, and you called them back, and they gave you phone trees, and you couldn't talk to a person, and you end up talking to a receptionist who has no power to make any changes on the bill or answer any meaningful questions, you'd say, this is a disgraceful business. And I think the many people in business who know that so much of local accountability is based on good faith and the public trust in individuals, and that's what creates the great American society, I think they would only say, hey, that's what we need from our healthcare institutions. So know that there's a group of us out there, doctors, who are trying to make healthcare more personal, more local, more democratic, and more civil. And I think thanks to your support, we've been able to get hospitals to change a lot of their practices. Most hospitals do the right thing, but the ones that have been behaving poorly, I think, do deserve the sunlight of accountability, and that's what we've been able to do. So thank you.
Yeah. Well, thank you. I mean, it's making a huge impact, both at our organization and beyond. So it's excellent.
Yeah. Absolutely. Well, Dr. Makary, any final thoughts? We'll leave you with the last word before we close it out. But is there any kind of if you're into lists, you can give us a top 3 most important takeaways for any listener out there to take away from this conversation?
Well, I think first of all, you guys are doing a great job. I love talking through these issues with you. So thanks for giving me the platform here to talk about,
of course,
this subject. We're winning. We want to get back to the things that we love in life. We want to get back to our football games and our businesses and our schools and our churches, and we want to get back to community. And a short amount of economic pain will provide long-term benefits in preserving life and allowing us to get back to what we enjoy in this country. Mm-hmm. So I think we've asked the American people to do a lot. The medical community has really asked folks to make massive sacrifices. I want you to know we take those requests seriously. We know that there's been massive sacrifices made. But I do think that even though this is a virus we don't control and didn't, have anything to do with starting, this is something where we're seeing the power of American ingenuity, capital, at this point driven by both the stock market and the government through Operation Warp Speed, and local businesses that are interested in doing what they can to redesign their business processes as temporizing survival tactics. We are heavily considering, and as every time I go on Fox or any other outlet and talk about what people need to do, weighing very heavily the cost of the sacrifice, not just the mitigation of disease, because we've got to balance both of those.
Of course. Excellent. Well, always a pleasure chatting with you. This today was certainly no exception to that. Very, very much appreciate your time and your valuable expertise and knowledge and wisdom about such a as you pointed out at the beginning, such a contentious issue, especially with a lot of the fallout of everything, of how it's impacting our daily routines, and the fact that we wear masks. I mean, mine's sitting right there. I know Michael's got his over by the side of him, and but we appreciate that there are experts such as yourself out there, kind of guiding the way and pointing folks in the right direction based on solid science rather than just kind of conjecture or knee-jerk reaction. So we appreciate you and what your team is doing. So.
Great, thanks, guys. Jim, Michael, Raul, great to be with you guys.
Great to be with you as well. Thank you.
Yeah.
Thank you, everybody, for listening in. Thanks, Michael, for manning the co-host chair, and Raul for running the board. We will be back next week with another fantastic interview, and hopefully maybe try and get like somebody really famous next time. I'm just kidding. No, we'll, Dr. Makary is about the level of fame that we get to enjoy here. So.
Right.
Nationally renowned physician.
I actually heard of Dr. Marty before he came to Thrive.
Yeah, before he came the first time.
Yeah.
My friends took me to a restaurant where supposedly you can see some celebrities, and I was very disinterested in that. But I sat there and they kept peeking over my shoulder and, that's this person. At the end of the night, I told them, I said, I'm sorry to disappoint you guys, but unfortunately the most famous person here is me.
Right.
Yes.
Yeah,
Nice.
That's kind of like you in a room full of B-list actors. It's not that impressive, but anyway, you're an A-lister in our book. So thank you again for your time. We appreciate you.
Thank you, guys, and thank you for your support of our research. I think it's a great thing you're doing. Thanks a lot.
Absolutely. Well, thank you again, and we'll see you next time, folks. Thanks for tuning in, and make sure to subscribe and so that you always get notified of when the latest and greatest Thrivenomics episode comes your way. And leave us some comments if you got any want to hear any specific topics covered on this show. We'd love to hear from you. So shoot us a note at Thrivenomics@thrivemortgage.com, and we will see what we can do to get that topic presented to you. So until next time, have a great one. Thank you for listening. We hope you enjoyed today's episode. The title sponsor for Thrivenomics is Thrive Mortgage. Licensed in multiple states across the U.S., Thrive Mortgage employs the best professionals, equipped with leading technology and the most efficient process to deliver a legendary lending experience. For more information about how we can serve you, or to find a local Thrive Mortgage professional in your area, please visit us at Thrivenomortgage.com. You can also contact us directly via email at Thrivenomics@thrivemortgage.com. Thrive Mortgage is an equal housing lender, NMLS ID 268552.